Hi, my name is Vanessa Ogothy. I'm a developmental paediatrician at Sydney Children's Hospital in Randwick, and I'm currently head of department at Tumberton, which is the child development service based there. I think there are two populations. There's the population that really knows their GP, and their GP is their care coordinator. And then there is a population who doesn't have that relationship with a GP. And I think they have very different models of care. And that perception that the paediatrician or the specialist is the person that manages that disorder becomes more and more entrenched over time. I think the much more optimal model is that the care coordinator is the general practitioner who then pulls in additional resources as required. And as specialists, we reinforce that idea that the GP is the first port of call, and if the GP is worried, they can contact us and we can escalate that way. So like everybody else, we have a finite resource, and it's nice to target the resource to where it's best used. It also concerns me that families often wait an extended period of time to come and see the paediatrician with disorders, conditions, concerns which would be much better managed and much more managed in a much more timely way at the general practice, be it warts, constipation, gastroesophageal reflux, etc. By deferring care, I think that that's not the optimal outcome for the child, and it also reinforces a message for families that they have to see a specialist. And actually what the families need across all chronic disorders is a tiered approach. So they need to have a general practice who has that overview of the child, overview of the family, who understands the history and is then able to pull in additional specialist resources as and when required. I think that's the best use of health resources, but I also think it's the most appropriate model of care for families. It means they can rapidly access care when they have concerns, they have confidence in their GP, and their GP has a mechanism for pulling in additional resources or support as required. So I think there's delay. I think that's probably the most important issue. The routine healthcare is neglected, so we see conditions presenting far later than they needed to. So our capacity to change the trajectory is diminished. Some of that comes from a perception that disability is not health, or that these children are not unhealthy, which often they're not, but they're at risk of poor health, and that sort of changing that conversation for families. But my primary concern is the delay in accessing care. So if they're seeing a paediatrician every 6 months, every 12 months, that you would defer management of a treatable condition, or even assessment for a significant condition that should be actioned much more quickly. GPs sit in a unique space within our system, so they are often the person the family first approaches when there's a concern about language development, learning, etc. So they're aware of the initial concerns, and in an ideal model, they would then continue to carry the family whilst we did the assessments, and if we have a definitive diagnosis, we communicate that back to the GP. The GP is aware of that, and we shift from a diagnostic phase for the family to a long-term care phase. Families with children with disabilities are often highly stressed. We know that family relationship and breakdown is much more common in families where there is a child with a chronic health disorder or a disability. Having care for the whole family means that I think that the child gets better care. So having someone who understands what's happening with the sibling who maybe has developed another disorder, an elderly relative, parental mental health, family breakdown, things that are not always shared with a specialist, means that the GP is in a much better position to understand the dynamics, what's reasonable to ask of the family, the degree of stress the family's under, and when the family needs additional supports. And that may be not within my power to provide, but certainly as a paediatrician, one of the jobs you do is advocate, and I do appreciate that we have more time for that and we have access to social workers, etc. But knowing from the GP that the family is really under stress will direct what I then decide to do with the family, or what additional resources need to be brought in to support the family. And that additional communication, that information that the GP holds that no one else has, is critical to the long-term well-being of the family unit and therefore the child. What I see too often, not just with general practice but also with paediatricians, is the families stop coming. They have an answer. It's very clear that the doctors can't fix it, and therefore there's no real reason to engage in healthcare. And what we know is that with routine surveillance and health promotion, certainly in adults, we found many more health disorders which we can manage, optimise health and well-being, and I believe the same is true for children. In an ideal world, that shift to managing the child as someone with a chronic disorder means that they would get annual check-ins. You would build up that comfort for the child within clinic to have their blood pressure taken, to have a look in their ears, be weighed and measured, all the things that you really need the child to be able to tolerate as an adult to be able to continue to provide that care. It also allows for early intervention when there are problems found. So I think it's important that the GP and the family understand that there are health issues associated with developmental disorders and intellectual disability, and that connection with the GP is core to the ongoing well-being of the child and family going forward, and we shift from that investigative and diagnostic phase to a long-term health promotion and surveillance phase. From my perspective, it's very different if you know the child from 2 and 3, they grow up with you, you learn about their interests, you're able to put them at their ease, you have that connection going forward. Then if you suddenly meet someone who's 15, who's bigger than you and potentially aggressive, it's a very different relationship, which again speaks to why that continuity of care with a GP is so important. Generally, I follow other people's leads. So if the carer comes in and the child is agitated, I would ask, what can I do to make things better? There is no one answer for everybody. It is an individual response. Sometimes it's the light in the room is too much. Sometimes it's the noise. Often waiting makes my patients very agitated. So certainly this is a population I work really hard to run to time for. They don't like hanging around in my waiting room. They don't like change, they don't like seeing different doctors, they don't like being in different rooms. So as much as I can to minimise that, and really working at the child's pace and understanding that, you know, it might take me 4 or 5 visits before I can actually get an accurate blood pressure, which is why it's important that I start taking a blood pressure when it's not clinically vital that I get a correct blood pressure. It's a skills development with the child. So we put it on mum, and then we put it on the brother, and then we do it on the child, and we do it by palpation, and then eventually we get an accurate blood pressure, and the same with weights and heights and ear examinations. There has to be a really good reason, a clinical, acute reason why I would push a particular component on an examination on a child. To me, it's much more about building comfort and coming to see the doctor is not a scary thing. Some families like to have video photo diaries. All sorts of iPad stories where, you know, we're going to go see Dr. Vanessa, and they know that Dr. Vanessa makes you weighed and makes you measured and takes your blood pressure and feels your tummy, and they can have that conversation and they can do that pre-warning with the individual child. But mainly it's just a matter of familiarity, of coming often enough and regularly enough in a predictable way that the child and the family feel comfortable.